With a focus on advancing emergency care, Zoll delivers innovative, user-friendly technology designed for where and how you work, and for the patients who rely on the care you provide. Zoll is committed to helping you save more lives.
First, I want to thank Professor Lim for inviting me to come. It's an honor to be at this meeting, and I've had a wonderful time being in Singapore for the first time as well. The talk that he asked me to cover was guidelines for hypothermic targeted temperature management in VF and non-VF arrest rhythms. And I apologize for my voice. I caught a little bit of a cold here. So I hope that it holds up for the 20 minutes. In terms of disclosures, as mentioned, I'm the immediate past chair of the AHA Emergency Cardiovascular Care Committee, have been on several ILCOR task forces as well, and have research funding for animal work in hypothermia, but no direct conflicts related to the clinical work in targeted temperature management. So one of the things I learned early from one of my mentors, Peter Saffer, was that there are very few things in medicine that are new in the time that you live, and targeted temperature management is actually one of those as well. So this is a study published in 1958 from Johns Hopkins University by Rainey Williams that looked at hypothermic targeted temperature management in post-cardiac arrest patients. And what you can see here is that they basically made a set of treatment recommendations, and I know Dr. Morley would be very difficult to handle this because it's really only a case series of 4 patients. And I'll also mention that none of them were in a shockable rhythm, so they were all PEA rhythms. But the recommendations are very interesting. So when you talk about who you would treat, the recommendation was patients who show evidence of central nervous system damage following cardiac resuscitation, how soon they should be promptly cooled, how cold, 32 to 34 degrees, and then how long maintained until there's evidence of return of neurologic function, and they go on to mention no longer than 3 days. So the question is, 58 years later, do we really have any different answers than we had back in 1958, despite millions of dollars in research and millions of patients studied? So what I'm going to do is go through the new guidelines for TTM, talk about these key areas, and then give a little perspective on at least our own practice. So which patients should receive hypothermic targeted temperature management? And I'll just pause for a second and say I use the word hypothermic targeted temperature management because technically, if you just say targeted temperature management, that could be really at any target temperature. And I think at least from our perspective, a temperature of 36 or below, I would put in the category of hypothermic targeted temperature management. And that's why I use that terminology. So the 2015 ILCOR guidelines say that we recommend targeted temperature management as opposed to no targeted temperature management for adults with out-of-hospital cardiac arrest and an initial shockable rhythm who remain unresponsive. And this is really based on the 2002 prospective randomized trials by Bernard and the Hockett trial. And this just shows the analysis of those two. And if you look at the summary data, again, the diamond there favors TTM. Now, when you go away from shockable rhythm, we don't really have the randomized clinical trials. So as you can see here, we changed from recommend to suggest for out-of-hospital cardiac arrest with a non-shockable rhythm. We suggest that TTM versus non-TTM is reasonable. And this is just the analysis of 3 observational studies showing somewhat discordant results with, but really not much significant evidence for outcome benefit, but really no evidence for harm as well. And then when you talk about in-hospital cardiac arrest, with either a shockable or non-shockable rhythm, our recommendation is that we suggest, again, TTM versus non-TTM for in-hospital cardiac arrest with any initial rhythm who remain unresponsive. And really, there's limited poor quality observational data for that recommendation, and it's really based mainly on extrapolation of out-of-hospital cardiac arrest data. So subsequent to those publications, there has been some additional studies published. I'm just going to talk about one of them because it does give a little bit more insight into the in-hospital and non-shockable question. So this was a study done by Sarah Perman looking at therapeutic hypothermia in post-arrest patients with an initial non-shockable rhythm. And what they did is, this is from a registry, multi-center registry, the Penn Alliance for Therapeutic Hypothermia, between 2000 and 2013. And what they did is they did a propensity-matched analysis of two cohorts of patients, one cohort treated with standard care and one cohort treated with hypothermic targeted temperature management. Excuse me. And this table just shows the matching of the patients. They were fairly similar in age, fairly similar in arrest duration. The proportion that were out-of-hospital cardiac arrest was 80%. The proportion that was witnessed was the same. And the interesting thing is that it did include a significant proportion of patients that were asystole as well. And in this analysis, they actually did see a significant therapeutic benefit for hypothermic targeted temperature management compared to the control group, both for survival here and then for survival with a CPC 1 or 2, which is a good neurologic outcome, the difference being 10% versus 20% with the odds ratio of 3.5. And if you break that down into in-hospital cardiac arrest versus out-of-hospital cardiac arrest, the benefit held up for both in-hospital cardiac arrest and out-of-hospital cardiac arrest patients. So again, this is just a small study, and there are limitations to the propensity analysis, but it's just one more piece of evidence that the population that we treat for either a non-shockable rhythm or in-hospital cardiac arrest does have the potential to benefit from hypothermic targeted temperature management. And if you understand the animal data would support that, most of the work that's been done in animals has used either both VFib and non-VFib models and showed a benefit in neurologic outcome and survival. So physiologically, it makes sense that hypothermic targeted temperature management should be effective regardless of presenting rhythm, unless the presenting rhythm is some other surrogate for something else like duration of cardiac arrest being much longer, and then the less likelihood of having a good outcome. But we still do need randomized clinical trials in this area. And this is just one trial that's registered in the clinicaltrials.gov that's going to look at targeted temperature management at 36 versus standard care in in-hospital cardiac arrest patients. So the study hasn't opened yet, but again, moving forward, hopefully we'll get more data on both non-shockable rhythms and on in-hospital cardiac arrest. Okay, so moving on beyond which patients, the next question that's led to a lot of controversy is how cold. And our new recommendation is that we recommend selecting and maintaining a constant target temperature between 32 and 34 degrees for those patients in whom temperature control is used. And that's a strong recommendation with moderate quality evidence. The original recommendation was 32 to 34, and that came out of the two studies that were published in 2002 by Bernard and the HACA group. That the Bernard study used 33 degrees as a target temperature, and the HACA group used the 32 to 34, and that's where the original recommendations came out of. Subsequent to that, and before the TTM trial, there was a study published in 2012 by Lopez de Sa that looked at 32 degrees as a target temperature versus 34 degrees as a target temperature in a small randomized pilot study with survival with good neurologic outcome as the primary outcome. But they only had 18 patients per group, so it was a very small study. But interestingly, they showed in the overall analysis that there was a trend towards better outcomes in the patients that were cooled to 32 degrees rather than 34. And then, although it's hard to imagine doing a subgroup analysis when you only had 18 patients per group, but when they did break out the patients with that VF or PEA, they did see a significant improvement in outcome survival with good neurologic function with the 32-degree group, which is here, versus cooling to 34 degree. So at least some small signal in a very small study in humans that cooling to 32 could be potentially better than 34. Subsequent to that, and probably most of you are familiar with the TTM trial, that actually randomized patients prospectively to 33 degrees versus 36 as a target temperature. And that was for out-of-hospital cardiac arrest or presumed cardiac etiology. They did take all rhythms except for asystole if it was unwitnessed. So they took witnessed asystole and they took PEA. So that does bring in to the scope more than just shockable rhythms. And you had to be comatose for at least 20 minutes, and then they were randomized to 33 or 36 for 28 hours. And the primary outcome was all-cause mortality. This is the temperature curves for those for the two treatment groups. And I think the most important thing to point out is, one, is that they actually achieved the temperatures that they tried to achieve. So the 36-degree group was kept pretty well at 36, with the deviation getting up to around 37, but the majority of patients below that 37-degree mark. And then the 33-degree group, again, although there's large variability, their average temperature was at 33. But the important thing is that neither one of these is, or the 36-degree group is really not normothermia, and it's really should be thought of as sort of two different doses of hypothermic targeted temperature management rather than hypothermia versus normothermia. So the results were there was no difference in the primary outcome of death at the end of the trial, 50 versus 48%. And if you look at even survival with good neurologic function, there was really no difference between the two groups. And multiple sub-analyses, some of which are shown here, some of which have been published in numerous subsequent follow-up publications, really have found no difference between the two treatment groups in any outcome parameter. So do we have the answer? Is it good enough to say that hypothermic targeted temperature management should be just in a range of 32 to 36, picking a temperature within that, and then moving forward? And I do think we need a lot more data. I think there's the potential that more severely injured patients, whether that be duration or for other reasons, could potentially benefit from a larger dose of hypothermia. And when you can think about the dose of hypothermia, that could be the temperature, so going to a cooler temperature, or that could be the duration of hypothermia as well. And I think ultimately, although there's clinical trials that are going on now, such as this one, which they're going to compare 33 to 32 to 34 with an intravascular device, so very tight temperature control in a very small range. That may show a benefit, but I think ultimately what we'll need to do to optimize the target temperature is really have some form of individualized care where you can assess the amount of brain injury that the patient has undergone and has ongoing, and then titrate your target temperature to maximize the therapeutic benefit. And I really think every patient, the target temperature is likely to be different, as well as the duration. Okay, so we did which patients, we did how cold. The next question is how soon. So ILCOR did not address a specific time, but they did address pre-hospital cooling because there were several studies that were able to be looked at for that. And the ultimate recommendation is recommending against use of pre-hospital cooling with rapid infusion of large volumes of cold IV saline immediately after ROSC. And that was mainly based on the Kim study and the Bernard study that looked specifically at rapid infusion of cold saline after ROSC, showing no difference in outcome. This is the temperature curve from the Bernard study. And you can see that in the hospital treatment group, which got its cooling when the patient arrived at the hospital, they arrived at the hospital a little bit over 35 degrees as their temperature, and then were cooled down to around 34 for their treatment time. And in the paramedic cold group that got 2 liters of cold saline in the field, they arrived at the hospital about 34.4 degrees. So it's really less than 1 degree difference in the patient's temperature by the time they arrived to the hospital. And both of them were at a lower than normal temperature. So I'm just going to overlay that on that, the actual temperatures that were used in the TTM trial. So one treatment group in the TTM trial was 33 degrees, and the other treatment group in the TTM trial was 36 degrees. And our new recommendation for target temperature is 32 to 36. So if 36 degrees is good enough to give you the maximum therapeutic benefit, then really there is no benefit or no need for early cooling, because the majority of your patients are already going to come in within target temperature. And really what you're doing initially is preventing rewarming, not actively cooling. And if that's true, then there really is no role for pre-hospital cooling at all, because the patients are already at that temperature by the time they get to the hospital. Now, the alternative perspective, thank you. The alternative perspective is that 36 degrees isn't the maximal benefit. And let's say that you have to get below 34 degrees to get the maximum therapeutic benefit. Then the strategies that were used in this study really are ineffective, because neither of the patient populations got to below 34 degrees early in their post-resuscitation period. And if that's the case, then we have a whole different perspective. Rather than saying pre-hospital cooling isn't necessary at all, pre-hospital cooling, we need a better tool and we need to be more effective at it for it to have its therapeutic benefit. Because just because you attempt to cool somebody, if you don't move their temperature into the therapeutic range, then you're not going to measure the benefit. So that gets into the issue of whether other techniques such as intranasal cooling, head cooling, something that can be more rapid, either intra-arrest or early post-arrest, could be beneficial. I still think we have to look at that moving forward. So if you look at the major randomized trials for time to target temperature, there is even significant discordance there, even after the patient gets to the hospital. So the Bernard study, actually the original Bernard study in 2002 did do some pre-hospital cooling as well as cooling in the ED, and they achieved target temperature at 2 hours. But the HACA trial actually had a median time to target temperature of 8 hours with an interquartile range of 4 to 16 hours. So that means that half the patients in that study didn't reach their target temperature until more than 8 hours after return of spontaneous circulation. And then in the Nielsen study, unless I missed it, I looked as many times as a number of times, and I did not find a specific report of their time to target temperature. But those patients were enrolled within 4 hours after ROSC. And again, it gets into this question of if 36 degrees is an adequate target temperature, then in the TTM trial, the 36-degree group was already hypothermic before they were enrolled. So how long? So again, when we talk about hypothermia, I like to think about it as a dose of hypothermia. So dose could be the target temperature that you use. Colder is a larger dose, but also duration could be thought of as a dose. And the OCOR recommendation that came out in 2015 is we suggest that if TTM is used, the duration should be at least 24 hours. There really is very limited data in humans looking at different durations of targeted temperature management. This just shows the two that were listed in the publication. Both were observational studies that saw no significant difference with cooling duration. Again, going back to, then falling back upon the clinical trials that were published, the Bernard study cooled for 12 hours, the HACA study cooled for 24, and the Nielsen study cooled for 28. There's animal studies that suggest that longer durations of cooling may be beneficial, but it really needs to be translated into clinical research. There's one planned clinical trial that hasn't been funded at this point, but this is from the Neurologic Emergencies Treatment Trial Network. It's trying to do an adaptive clinical trial that looks at cooling durations ranging from as short as 6 hours up to 72 hours and trying to compare that survival with neurologic function with that. And this is the kind of trial that we, if we are going to solve the duration question, is one approach. But the other approach could be that if, again, going back to individualized care, if you have a way to monitor ongoing injury in the brain, monitoring ongoing electrophysiologic function, you could actually titrate your duration of therapy based on the ongoing injury mechanisms and individualize that to patients. And finally, I'll just mention rewarming rate. Again, very limited data. The OCOR guidelines have no recommendation on rewarming rate. In the published trials, it ranges from 0.67 degrees per hour down to 0.33 degrees per hour. And again, we don't really have any randomized clinical trials. Looking at rewarming rate, there's one registered in clinicaltrials.gov that's going to compare 0.25 degrees per hour versus and that should be 0.5 degrees, not 0.05. So it's 0.5 versus 0.25 rewarming rate, and hopefully we will get some information regarding that. And the rewarming rate is a little bit tricky depending on what you consider the therapeutic range, because if you do a slower rewarming rate, you're actually in the therapeutic range for a longer period of time. So it's going to be a mixture of a duration study as well as a rewarming rate study. So with that, I'll just remind you again, back in 1958, these were our recommendations. I'm not sure that they're all that different. We say evidence of central nervous system dysfunction. We say unresponsive in terms of won't respond to commands. The range we've expanded to 32 to 36, from 32 to 34, but I think there's a number of people that still believe there's the potential for better benefit at lower temperatures. I think for how soon should be promptly cooled, I'm not sure we can say much more than that, except cooling as soon as feasible. And then for the duration, we really don't know. We're just using the numbers that were used in the clinical trials. So just to summarize, for hypothermic targeted temperature management, again, a very important intervention post-arrest. I think there's convincing evidence that it does improve outcomes. Our recommendations are, and this is what we do at our institution, is anyone that's unresponsive after return of spontaneous circulation for at least 15 or 20 minutes, either in hospital, out of hospital cardiac arrest, shockable or non-shockable, we will apply hypothermic targeted temperature management. The guidelines indicate 32 to 36 based on the randomized clinical trial data that we have. Our institution, we've stuck with 32 to 34, still waiting for more data before we make a change. How soon? I think as soon as feasible is probably the right answer. And the reason I think that's important is because there still is an opportunity in the pre-hospital setting or even in the intra-arrest setting that cooling could be beneficial if we figured out a way to get effective targeted temperature management using strategies other than cold saline, which seems to be not effective in moving the temperature very much. And then how long? The current recommendation is greater than 24 hours. This is simply based on some animal studies, but really based on, that's the durations that were used in the majority of the clinical studies, and a rewarming rate of less than or equal to 0.5 degrees per hour. Again, basically based on what's been done in the clinical trials, but not based on any randomized comparison of other rates. And I think with that, I'll end. I'm glad my voice sort of held up to the end, and I apologize for that.